Hello, my name's Gary Hargraves, President of NIFA Medical Billing. If you're not familiar with us, then you should know that we've been billing exclusively for non-MD first assistants for over 18 years now in 30 states. If you're interested in billing and getting reimbursed for your first assisting, then through your research, you probably already know that there's just not very much information out there on the subject, not even on the internet, which is kind of interesting. And that's the purpose of this video, is to give you the basics on what to do to get started. Now we have a couple of useful resources that are available to you. The first one is our LinkedIn group. It's entitled Surgical First Assisting, Billing and Reimbursement, and our website at nifamedicalbilling.net. Not long ago, a young lady posted on our LinkedIn group and she said, "I just finished my RNFA course. Now what?" Well, that's really a good question when you think about it. Maybe you've asked a similar one. And so what I'd like to do is to discuss 5 things that you need to know and do to be successful in not only billing for your first assisting, but getting reimbursed. So let's get started on the first point. So point number 1 is you need to apply for independent allied healthcare provider privileges at your facility. So you want to do that right away, as soon as you can, because that typically takes 30 to 90 days, depending on your facility. Point number 2, you obviously need to find a surgeon, if you haven't already done so. But you don't want to just get any surgeon. You want a surgeon that's going to cooperate with you. Cooperate, what do we mean by cooperate? Well, he doesn't expect you to work for free. He knows that you need to make a living. And so he's going to help you out. One of the most important things he can do to cooperate with you is to line you up or introduce you to an individual, an employee in his practice that's going to get you the information that you need in order to bill. Now, the most important information that you need from the practice is the billing codes. That's the diagnostic codes and the procedure codes. And the best way to get those codes is to get a copy of the surgeon's CMS 1500 form. What is the CMS 1500 form? Most of you probably don't know. Well, I'd like you to think of it as an invoice. All providers use a CMS form to electronically transform this to the insurance companies. And it has the insurance company's name, obviously, the patient's demographics, the billing codes, and your information on it. So if you get the surgeon's CMS 1500 form through your contact, then they will fax it to you and so forth. So you need to set up some sort of an arrangement that works for you and for your contact to give them the patient's name and date of service of when you first assisted them. They look up, for example, Jane Doe, date of service. They find that Jane Doe, double click on it and hit print, and they print up a CMS 1500 form. It has all the information that your biller needs to bill for you. And then they will fax it to you, and then you fax it to your biller. So that's very important. It's the best way to get the information. First reason is that it reduces the amount of work that your contact has to do, just a couple of clicks, and all you have to do is fax it to your biller, and then you have a hard copy. The second reason it's the best way is it reduces the chance of typo errors, which is very important because that will reduce the amount of delays that you have due to errors. The alternative, for example, NIFA medical billing, if you can't get the CMS 1500 form, then we have what we call a patient profile. It has all the same fields on it as the CMS 1500 form. The difference is that you need to get the billing codes from the practice, and then you can get the other information off of your face sheet at the hospital. And then you take that information and put it on the patient profile. Well, obviously that takes a little bit of labor, a little work. You got to hand write it in and fill it out, or you can get a template from us and you can type it in Microsoft Word. But the downfall of that method is obviously it takes more labor, more time for you, and you're already busy. And it also increases the chance of typo errors. For example, you get the information from your contact. Well, they might write down or type in the wrong procedure codes, just one digit off, and it's going to delay a reimbursement. Then you get the billing codes from your contact, say through a fax, then you need to put it on the patient profile. Well, there's another opportunity to make a typo. Then we get it, and then we have to take that information, put it into our system so that we can transmit it to our clearinghouse and on forward in digital format to the appropriate insurance company. You see, there's 3 chances of typo errors which can delay your reimbursement. So to reduce that, the best way is to obtain that CMS 1500 form, which is part of that cooperating. So that's ideal. Another way that the surgeon can cooperate with you is to allow you to appropriately bill the patient. What do we mean by that? Well, as you probably all know, maybe even for yourself, most people are increasing their deductible to lower their monthly premiums. And so the average deductible today is $4,500. So regardless of who you are, even a doctor that's first assisting, they're not going to get paid until that $4,500 has been met. And so part of the patient's policy is to pay out of pocket the first $4,500. So you need to have the surgeon allow you to do that, to bill a fair amount to the patient for your deductibles or co-insurances. And we can be reasonable on that. Also, because most insurance companies won't let you in network, it's beneficial if you can bill the patient a lower amount than what the out-of-network deductible would be. And so what we suggest is for everyone to have the patient sign what we call a patient responsibility and consent form for a fixed amount. They can sign this in the surgeon's office during their pre-op consultation where they're signing all the papers for the surgeon. And so they agree by their signature to pay any co-insurance or deductibles, excluding out-of-network deductibles, for a reasonable fixed amount. And most of our clients bill somewhere between $200 and $250 for that fixed amount. So to give you an example, let's say we bill the insurance company for a procedure for $1,000 for your first assisting. On the explanation of benefits that you receive, they show the allowable amount that they would pay is $500. But you don't get that $500 because the whole $500 goes to the deductible or an out-of-network deductible. Well, it's not fair to bill the patient $500 or even the full $1,000 for the out-of-network deductible, because it's not their fault that you can't get in network, and it's not your fault that the insurance company won't let you in network. So rather than bill them even the allowable, we just bill them the agreed fixed amount, whatever it is, $200, $250. So they're really kind of getting a discount, and you've already told them up front that there is possibly an out-of-pocket financial liability if their insurance policy doesn't cover your expenses. So that's fair to the patient, and if they don't want to agree to that, they can say no, and you could tell the practice that if a patient really is upset about that, to just waive that fixed amount. There's no reason to push the issue. But that's the best way. Otherwise, you're going to be doing way too much first assisting for free. So those are the first 2 points. Point number 3. Somewhere in your conversations with the surgeon, you need to ask them the question, very important question, what percentage of your caseload is Medicare, doctor? Now, why is that such an important question? Well, because you probably already know if you're a CNOR RNFA without an advanced practice license, you can't bill Medicare. Therefore, all of those Medicare cases most likely are going to be zero pay. And I'm sure you don't want to work for free. So if he says 50, 60%, that's most likely too high a percentage to make it viable. There might be some cases where it could be, but most of the time it's not going to be worth doing 5 out of 10 cases for free. So maybe you need to find a different surgeon that has a lower percentage. And even nurse practitioners out there, you need to be interested in that as well. Why is that? Well, even though you can bill Medicare, you probably know pays considerably less than commercial insurances. For example, if you assist on a total knee Medicare patient, Medicare pays $176. And if they have a supplemental insurance policy, they pay another $40 and change. So you get a little over $200 for a total joint on a Medicare patient. A commercial insurance on the same procedure pays anywhere from $500 to $1,200. So you can see you want to work smarter, not harder. So the lower percentage of Medicare, the better. Point number 4 is states. There are 16 states that have legislation. Now, I'm not counting West Virginia because they only accept Medicaid reimbursement, so that doesn't apply to most people. So let's talk about states that have legislation. What does that mean? Well, basically, they're all different, but basically the wording is that if the patient's policy would reimburse an MD, they must reimburse an RNFA. So that's pretty cool, right? So let's see which states have that legislation. I'm going to go from west to east. We've got Washington, Oregon, Montana, Colorado, Texas, Louisiana, Florida, Georgia, Kentucky, Minnesota, Illinois, Rhode Island, Maine, Maryland, New York, and New Jersey. So those are the states that have legislation. Now, if you didn't hear your state, that doesn't mean you can't bill. Remember at the beginning of this video, I said that we bill in 30 states. So you see there's quite a few other states that you can live in and do quite well. A couple of them that we do good that don't have legislation are Nevada and Arizona. But there's others too. So if you'd like to know how your state is, at the end of the video or on our website, you can get our email address and or our phone number and email me or drop me or call me, I should say, and I'll be happy to answer you forthright on whether your state is good, bad, or indifferent. So no sales pitch. We're here just to share the information. Now, point number 5 is specialty matters. Not all specialties are the same, and so you want to get a specialty that pays as high as average as possible so that you're making more money with less work. So I'm going to name off the better specialties to the least specialties and give a few reasons why and some examples. So without a question, the best 2 specialties are neuro and spine surgery. Off the chart reimbursement wise. Average reimbursement is probably $1,500, $2,000, $3,000 and more are not uncommon. So it can be a life-changing experience. The downside is that most of the surgeons know that, so they hire PAs or nurse practitioners as employees, but not all of them. We bill for quite a few non-MD first assistants that assist neuro and spine surgeons. So keep your ear to the ground. Even if you fill in once in a while, we have a few providers that fill in vacations and when they're sick, and at least you get the foot in the door and you do a case here and there and make $2,500 or more on those cases. Hey, that's good. So that's the best one. Another real good one is open heart surgery. Cabbages pay probably on the real low side $600 up to $2,000, but downside, it's because of Medicare probably best for nurse practitioners to assist on those. And then from there, plastic surgery is really good, especially if you're going to do this on a part-time basis. The reason is the volume isn't that high, but the reimbursement is. So that's good if you're doing this part-time. So we're not talking about cosmetic surgeries, but you know, those bigger cases like breast reductions, reconstruction, and trans flaps. And they reimburse $1,000 and up as a rule, unless it's a Medicare case. For example, I have a provider that I've been billing for over 16 years in the Houston, Texas area. She works full-time at a hospital, and she has one plastic surgeon who calls her up whenever she gets a large case, and they make arrangements as to what a good day to schedule the surgery on. And she does, on average, anywhere from 20 to 36 cases a year. Probably averages about one every other week. And over those many years that we've billed for her, she's made as low as $20,000, but as high as $36,000. So I think you would agree that's a pretty good job, part-time job, that makes it worth her while. So that's a good one to watch out for. Another good specialty is sports medicine. Sports medicine is great because the patients are usually younger and active, and there's therefore low Medicare, and it's got a relatively high average reimbursement. ACLs pay probably average a shade under $500 up to $1,200 and sometimes more. Rotator cuffs in the $400 range. So that's good. I have a guy I've been billing for 18 years in Ohio, and he works 3 days a week for 3 different orthopods, and last year he made right in the neighborhood of $300,000. Unusual. He's specific. We've been billing him. We've really fine-tuned his practice. He has that patient responsibility form in effect. His doctors really cooperate with him. So he does very few cases for free. Gets $250 for those cases that insurance companies that don't pay him. We have very few problems collecting from his patients. So it just gives you an idea of what's possible out there. Not that every sports medicine practice is going to produce that kind of money, but it's a great specialty. And then from there, more common ones we do are OB-GYN. OB-GYN, the hysterectomies pay in the neighborhood of $400. C-sections about $250. One caveat there is you need to be careful if you live in an area where there's a lot of people that are on state aid. So most states you can't bill welfare or Medicaid, and even if you can, like we have a provider in Florida and she does a lot of C-sections and only gets $106 for them when they're state aid. So probably not a real viable thing if you got too high of welfare patients. And then from there, general surgery is kind of on the least attractive. The only reason for that, not trying to knock anybody that's in general surgery, but it's got a couple things that are going against it. Higher Medicare than you'd like to see, and the average reimbursement is kind of like $200 to $300. And then there's a few cases mixed in there that are not medically necessary, like some of your hernias. So by the time you put all that together, unless you've got that patient responsibility form in effect, usually it's going to be too much work in a lot of cases. There's a lot of volume, but not getting enough to make it viable in most cases. Not all, but most cases. Now, if you're new at first assisting and you need to get your skills up to where you would like them, 8 to 10 on a scale of 10, then maybe you take on a general surgeon to help him so that you can get the reps and get your practice up to where it should be. And then you probably want to look for a different specialty that has a higher average and a lower Medicare. So those are the specialties that we recommend. There's a few others, but those are the most common ones. If you have any questions, need more details on any of that or another specialty, like I said, drop me an email, give me a phone call. I'll give you a candid answer, the best that I can. I don't have all the answers, but I'll give you the best that I have. And so we'll wrap that up. I appreciate you watching the video. We're going to come out with some other ones. I think I'll do a video on the patient responsibility and consent form and cover that in more detail. So until then, we'll see you. Bye.